Hi, my name is Aaron Gerds, and I'm the editor-in-chief of ASH Clinical News. Welcome to the ASH annual meeting for 2024. We're absolutely thrilled to have you here with us for our on-site coverage. And it's my absolute pleasure today to be accompanied by Dr. Dimopoulos, who's going to talk about his abstract in smoldering multiple myeloma. Well, welcome.
Thank you for the invitation.
Yeah, it's a pleasure to be here with you here today. Could you just briefly tell me a little bit about the study? You were looking at smoldering multiple myeloma and particularly ways to prevent progression into overt multiple myeloma.
Absolutely. First of all, it is good to realize that smoldering or asymptomatic myeloma is quite common. There was this population study in Iceland where they screened thousands of citizens above the age of 40, and they found that the prevalence of asymptomatic or smoldering myeloma was 0.5%. So this is quite often. Now, the majority of patients with smoldering myeloma, they have low risk for progression. They resemble sometimes more like MGUS, and for this type of individuals, it is absolutely safe to follow them closely. On the other hand, there is a subset of patients that has some high-risk features, meaning features, laboratory parameters that help us predict that their likelihood to progress to symptomatic disease in the next couple of years is 50% or more. So for this type of patients, one may want to develop some kind of treatment that could intercept the disease. In the past, there have been some randomized trials. Actually, even interferon alpha was evaluated many years ago. Lenalidomide, with or without dexamethasone, had some success, but they subjected patients to a continuous exposure to lenalidomide with all the side effects that one may have. So Aquila was based on initial observations that Daratumumab, which is an anti-CD38 monoclonal antibody, had single-agent activity in a phase 2 study in patients with smoldering myeloma. And then this formed the basis to develop a large registrational phase 3 study, which included patients with high-risk smoldering myeloma. Now, the definition of high-risk smoldering myeloma is not exactly what we use today. This study was designed in 2015. It started in 2017. And the current Mayo 2018 system that we use was not at that time recognized. Thus, one may say that among the population of the Aquila study, there are some true high-risk patients and some who have intermediate or even low risk. So the study was designed as having a very thorough screening, a baseline evaluation with modern imaging techniques to rule out that we would include patients who may have occult asymptomatic lesions by using PET CTs, MRIs, low-dose CTs, detailed imaging and modern imaging examination. So we were sure to rule out patients that would need treatment anyway. Then the patients were randomized to receive either Daratumumab for a fixed duration of 3 years and then stop, or being in active monitoring. So in both groups, the monitoring was thorough. Every 12 weeks, we had blood urine tests. Every year, we would repeat imaging modalities. And every 1 or 2 years, we would do bone marrow. So we wanted to make sure that both in the control group and in the investigational group, the patients would be followed as closely as possible to avoid end organ tissue damage as much as we can. We saw, and this was quite impressive, that the administration of Daratumumab was able to reduce by 50% the chance of progression or death to symptomatic myeloma. The definition of symptomatic myeloma were based on what we call CRAB criteria or SLIM criteria. So they were well-defined criteria to say that this patient progressed to symptomatic disease. The other issue which I believe is important is that despite the fact that we gave Daratumumab for 3 years, we continue to see a benefit several years after treatment was discontinued. For example, at 5 years, the difference is about 20%, even if the patients had discontinued therapy. So maybe Daratumumab altered the course of the disease. It's not like having an effect, and when you stop the drug, then the curves, come together.
Back together. Yeah.
Now, the tolerability of the drug was good. Only 5% of the patients had to discontinue because of some side effects. There was no signal for second primary malignancies. The incidence was similar among the 2 groups. The progression-free survival too was better with Daratumumab, indicating that exposure to Daratumumab did not compromise the treatment of a patient who became symptomatic and who needed anti-myeloma therapy for symptomatic disease. And furthermore, there is evidence of improved overall survival. It's early in the study, but the hazard ratio is 0.5. There are twice as many deaths in the Daratumumab arm as compared to the control arm, and the majority of these deaths are due to disease progression. Another interesting observation is that Daratumumab not only delayed the development of symptomatic disease, but also decreased what we call end organ damage. There were fewer patients that progressed with fracture. There was no renal impairment. The levels of anemia were lower. So there was not only a delay in the progression, but also the progression was less clinically obvious or less clinical deleterious for the patient. So I believe overall that this treatment, as I said, this is a registrational study, and we'll have to wait to see whether FDA, EMA will approve Daratumumab for treatment in myeloma. Of course, physicians and patients make their own decision, but I believe it's important to have the option that would be reimbursed and covered by insurances throughout the world for patients with high-risk smoldering myeloma. When these are diagnosed, let's say within the first year of diagnosis, to have the option of being treated with Daratumumab, because this improves progression to symptomatic myeloma, decreases end organ damage, and also improves overall survival.
Well, thank you. And I think that's 2 really good points you brought up there over the course of your explanation of your work. Was one, even though the definition of high risk versus low risk changed during the interim, during the duration of the study, there was still a splaying of those curves, and still a measurable benefit.
And if I can add, the greatest benefit is in the high risk group according to the current Mayo criteria. So the median time to progression in the control arm was 21 months. It was not reached for Daratumumab, and the hazard ratio is 0.36. So I think that this is a subset of patients that they truly benefit from this treatment.
It almost sounds like they have overt multiple myeloma, but they're just not quite there yet, and you're trying to head things off at the MS. And then, so there's a trend to a better overall survival.
Yes.
Is there an intention to keep following these patients for a while to make sure that the curves stay apart?
Absolutely. This is a great point. There will be a follow-up of these patients. There will be further analysis because we have data on cytogenetics. We will have data to see whether the greatest benefit as far as survival is concerned is in the current high-risk group or overall. Yes, the study will be followed.
I had another question about the Daratumumab and using it earlier on. Daratumumab is such an important part of the treatment of overt multiple myeloma, if you will, symptomatic multiple myeloma now. And does using Dara early on then make it more difficult to use Dara later on, or do you have to switch out the agents, or can you reuse it later on?
Right. That's a great question. As far as the data that we have from the study with PFS2 in favor of Daratumumab, there is no signal at this point. However, now we know that Daratumumab will be used more and more often.
Yeah.
The fact that we give Daratumumab for a fixed duration of time and we let patient continue on follow-up and maybe progress off Daratumumab, this may indicate that retreatment with Daratumumab for a patient who has responded but has not progressed on Daratumumab may be reasonable. Now, you could ask me how you will deal with a patient who progresses on Daratumumab. Of course, for this patient, there are other treatment options. Now, in myeloma, we have bispecifics, we have CAR T cells, we have many, many regimens, and for these particular patients, I believe that one of these therapies could be appropriate.
Yeah. You mentioned that there's a low treatment emergent adverse event rate leading to discontinuation. What were some of the reasons that patients stopped the Daratumumab when they were on it during this study?
Right. Okay. We know that Daratumumab can cause infections. Infections, usually resolved. However, this study was also progressed during the COVID area. We had some patients with COVID. There were some patients that, occasional patient or physician that decided that maybe a more complex therapy is suitable if they should be treated, all kinds of reasons, but, at a very low percentage of 5% low rate.
So with any study looking at, a preemptive therapy versus an observation, a careful observation, there's always the question, are we actually making people better, making them live longer? And there's some may say, well, gee, is the cost of the medication, the cost of the potential adverse events worth treating earlier versus later? And do you have any insight into how valuable this could be for patients?
Well, if you have improved PFS, improved PFS2, and also survival, I think you have all the pieces that you need to say that at least this should be a treatment option. And frankly, I believe that we won't see any more trials in smoldering myeloma with the control arm being observation.
So you anticipate this becoming the control arm someday?
I think so.
Yeah.
I think so. And of course, the moment that you decide that you will treat a patient with high-risk smoldering myeloma, the treatment decision will be based on the age of the patient, his life expectancy, comorbidities. For example, for a young patient who has a high-risk smoldering myeloma, I would use a combination regimen. I would go for high-dose therapy. I would try to, induce MRD negativity. There are some preliminary studies with bispecifics in smoldering myeloma.
Yeah. You're already preempting my next question. Is Dara has been shown to do this in smoldering myeloma. Are there other therapies you could see that could potentially come into the space of smoldering myeloma that can alter the course?
Absolutely. Combinations, for example, the standard of care for active myeloma is Daratumumab with bortezomib, lenalidomide, and dexamethasone, followed by high-dose therapy. So I think for a 50-year-old patient who is considered high-risk smoldering, one may want to use this pathway. However, I believe it's important to have at least a treatment, a drug that is available and reimbursed for patients with smoldering myeloma. And I believe this is likely to happen with this study.
Yeah. Well, thank you so much. Thank you so much for spending the time with me
Thank you
today
very
and with
much.
our audience. This is the 10th anniversary of ASH Clinical News, our news magazine bringing clinical news to the world of hematology. And I have to say for myself that the advances in multiple myeloma in the last decade have been absolutely remarkable. And
So we keep you busy.
you keep us very busy, and that we thank you for that. And I'm sure the patients around the world thank you for that. So, but again, thank you for spending time with us today.
Thank you for having me.
And I'd like to thank you, our audience, for joining us today to have this discussion about this really important abstract in smoldering multiple myeloma and how the field has been advancing over the last decade. You can read about this abstract and all of our on-site coverage in ASH Clinical News.